Dr. Chazal, for that kind introduction. So, I'm not going into greater details of artificial intelligence in clinical settings because much of it will be spoken by Dr. Rick Chazal. I'm going to look at a broad sweep of how we can use artificial intelligence across cardiology and cardiovascular health. So, what are the emerging applications of AI in cardiovascular public health? First, it's extremely useful in surveillance, screening, and risk mapping, and I'll show you some examples of how it works. So, it can identify potential health issues in population as well as help in shaping the policies. Then, second is in prevention and early detection to mitigate disease impact through early action. So, you can actually identify people with, for example, early atherosclerosis, preclinical heart failure, and several other areas which, when detected early, can have better quality of life and longer life. The third area is precision public health, where you can tailor interventions for specific populations. Just to give you an example, the hypertension guidelines for Indians have been based on Western guidelines. And for long, we have been the Western guidelines that said we should use beta blockers and diuretics as the first line drugs. Now, when you look at South Asians, how do you define a South Asian phenotype? The person has high risk for diabetes, has low HDL cholesterol, has high triglycerides, and is somewhat physically inactive. And what does beta blocker do? It raises HDL, raises triglycerides, increases the risk for diabetes, and causes fatigue so people don't move. So clearly, we require our own data, and therefore, that's where precision is public health is precision interventions will be extremely useful. Then we can look at health system optimization to enhance the efficiency and effectiveness of healthcare. And most important is equity and accessibility. And AI gives us the wherewithal to ensure equity and accessibility, providing fair access to all. Now, there are several ways we acquire data. We acquire data without AI. What we do is we acquire data on lifestyle, we acquire data on the environment, we acquire data on medical conditions, we acquire data through electronic health records, wearable devices, then obviously genetics and omics. And we use this for risk stratification, diagnosis, and outcome prediction. The question here is, does AI help? Let's consider this patient, a 60-year-old man with long-standing hypertension, history of tobacco use, recent emergency department visit for shortness of breath, chest CT, non-contrast, non-ECG gated, showed right lower lobe pneumonia, treated with antibiotics. After treatment, he is discharged. He goes home with the label that he's healthy since the acute pneumonia was resolved. No further cardiovascular preventive evaluation is done. Is there a possibility that Mr. S has a cardiovascular condition that went undetected during this visit? And this is where AI can help. A routine non ECG gated CT scan of the chest can pick up incidental CAC and increases the risk. Once you have CAC, the risk is higher. For example, if you have a CAC score of more than 100, and even if it is incidental, we need to evaluate that. So automated EHR alert can be triggered whenever there is clinically significant CAC. And the alert informs the clinician to broaden risk assessment to include lipid panel, hemoglobin A1C, urinary albumin creatinine ratio, and anthropometric measurements, and provide appropriate treatment. So this is just a simple example. The second is, all of you heard about Framingham risk score, the various risk scores in the world. Now we have the Prevent score in the West, and we have specific scores also in China and India. Now, AI has always been using cross-sectional data, but there are recently data which uses longitudinal prediction. Now, this is data from pooled cohort equation where there's a risk comparison using standard regression models. That's what we use when we develop risk scores, as compared to AI-based risk modeling. The red straight line is the AI-based risk modeling, and the dotted ones are the regression scores. And you can see how AI performs better in when you use uh, when you use dynamic deep hit, which is a kind of AI-based analysis, and the area under the curve, an area under the curve of 0.72 is considered very good, an area under the curve of zero point 0.8 and above is considered excellent. And you can see here area under the curve with the AI-based risk prediction is 0.82, and the Brier score, the lower the Brier score, the better. The Brier score is, I think it should have been 0.05 by mistake. It's zero point 0.5. Sorry for the typo. It's kind of excellent. In India, there's a large EHR-based data which shows the accuracy with AI is around 80% as compared to applying a Framingham risk score or a Q risk score 3. So clearly, AI risk scores are better. The third area where we can look at using AI is in prediction of complications in patients with disease. For example, in a heart failure, can we predict ahead of time who's going to get into complications, who's going to require admission, who's going to have a high NT-proBNP? We did a small pilot study and looked at NT-proBNP trained algorithm. So there are several things in this algorithm. I'll talk about it a little later, and compared it against weight, because weight is one of the common things we tell patients to measure their weight, and then any sudden increase in weight, we know that there is a complication. You can see here how an NT-proBNP trained program predicts future higher levels of NT-proBNP. In the second panel, you can see the algorithm can trigger by saying that this is the patient who requires immediate attention, and it is actually almost 2 to 3 weeks ahead of time. And therefore, AI has got extreme utility in these kind of things. The last area is preclinical disease. Now, the conventional way of doing it is you have symptomatic disease, there are certain ECG changes where we are trained to look at the ECG changes. But we now have mechanisms by which you can identify preclinical disease, whether it is cardiomyopathy or even future coronary artery disease, future heart failure. So this particular study, called the recommended study, used an AI model which detected individuals who are at a high risk for 7 different types of structural heart disease with phenomenal 0.91 area under the curve, based on more than 2 million ECGs from around 484,000 individuals. So AI will likely have a very big role in the future. So we all know all of this. How do we apply it in our settings? Because I think clinical settings, it's very clear that you can use this, but there are several different settings where we can try and use them. I want to show one example of how we can understand the mechanism, and I'm going to show you the case of air pollution and cardiovascular disease. How do you study the relationship of air pollution and cardiovascular disease? Very simple. We look at an exposure, we look at an outcome, and adjust for the confounders without any bias, and we get the result. For blood pressure, it's easy because it's inherent in the individual. For diabetes, it's easy, inherent in the individual. How do you assign air pollution? And that's where AI can help. So for that, you require a cohort. If you have to link it to a disease, you require a cohort. We established a population-based sample of around 21,000 people and followed them up for more than 15 years, accruing 200,000 person years. And it is representative of two large cities in India. And it's a very well, carefully phenotyped, geocoded, biobanked study population. And just to give a context, it's 3 times larger than the Framingham cohort. In terms of air pollution, we developed an exposure model using AI-based techniques to predict daily PM2.5 concentration at a 1 kilometer resolution. That means we create a model and say, okay, in this room, what would be the PM2.5, which is a measure of air pollution, and assign it to one of the individuals here. So we had a total of 1635 grids in the city of Delhi, because it's 1635 square kilometers. Over a 7 year period, that is over 2,557 days, we obtained air pollution data on a day to day basis. We had close to 4.2 million observations. And we obtained data from several sources. We got a daily average PM 2.5 from the monitoring stations. We obtained satellite data. A satellite goes around every city of the world, and you can get the aerosol optical depth, which gives you air pollution data. we obtain data on emission inventories. You have to adjust for weather because PM 2.5 is not static, and then we also have to adjust for land use. Doing all this, we use several machine learning models and trained the program to actually look at what is the PM2 predicted PM 2.5. We use deep learning, gradient boosting, extreme gradient boosting, and random forest methods, and use a chemical transportation model to obtain PM 2.5. And you can see here on a daily basis in the city of Delhi, we could predict based on the pollution levels, the mortality keeps increasing. At 160, the mortality starts tapering off, but you can see the percentage change in mortality. And we linked it to various risk factors such as hypertension, high blood pressure, diabetes, dyslipidemia, stroke, acute coronary syndrome, and heart failure. And we have now extended this to countrywide and studied interactions among multiple variables. I'm just showing this example because we think of AI in clinical utility, but you can look at social determinants and you can link it to several diseases. This is a summary of hypertension. We can see even reducing the PM 2.5 from 100 to 75 can reduce prevalence by 5%. That's the power of AI in population health. What about personalized disease prediction and management? How can we identify subclinical disease? How does precision prediction and management improve efficiency and outcomes in such populations? This is where we use the same cohort, and here we are doing imaging studies such as echocardiography, cardiac CT, hepatic fat measurement, carotid IMT, wearable devices, and others in 14,000 community living individuals. We're also predicting future occurrence of Alzheimer's and dementia by using functional MRI in younger people and advanced biomarkers for early diagnosis of dementia and Alzheimer's disease. AI is also useful in detecting behavioral concordance between spouses. So we are using wearable devices here and looking at spousal concordance in terms of their behavior, and this can be used for behavior modification. Lastly, I think we need to look at the broader picture and look at how several things interact together in terms of increasing risk. And we all know that infectious diseases are, the deaths are much higher in patients who already have chronic diseases. We saw it in the COVID pandemic. Climate change is the biggest elephant in the room now, and it can do several changes, including interacting with temperature, interacting with air pollution, and causing extremes of weather, resulting in mortality. In addition, climate change also impacts food systems, and at a larger level, the calorie intake comes down and micronutrient intake comes down. So you can use AI to model and say, okay, this is a water depleted area. What can we do about it? And how is it correlated with cardiovascular disease? So beyond looking at clinical correlates, we could look at multiple things using AI. The last point I want to make is at the level of the health system, what can we do in terms of healthcare inclusivity? So we require to reimagine the health system where we require community health workers or non-physician healthcare provider, but can we pair them with simple technologies developed with AI? That's a question which we posed. So we developed what is called as a clinical decision support system, which are computer-based programs that analyze data within EHRs to provide prompts and reminders to assist healthcare providers in implementing evidence-based clinical guidelines at the point of care. The key functions of the clinical decision support in CVD care is it provides reminders for screening for risk factors. It flags cases for ANC, antenatal care, diabetes, hypertension, or hyperlipidemia. It can provide information on treatment protocols. It can prompt questions on medication adherence, and it can provide tailored recommendations for health behavior changes. The CDC USA, this was way back in 2010, recommended that implementing CDSS is among the best practices in the healthcare system interventions. But at that time, the evidence base for this was very limited. I mean, the evidence base was strong, but it was not scaled up. It was not known in other countries. This is an example of a trial that we did in patients with diabetes and used electronic decision support to tell physicians about personalized care of these individuals. And when you look at it, if the physicians agreed to the clinical decision support, so they had four criteria to agree. One, they had to get the HbA1c, A1c to a certain level, systolic blood pressure to a certain level, LDL cholesterol, and have to provide advice on smoking. Wherever the clinical decision support system prompts were accepted by the clinician, the control was very good. You can see here the last one in terms of the hemoglobin A1c. You can see here how better it's controlled when the DSS prompt has been accepted across all the visits. Similarly for blood pressure and similarly for LDL cholesterol. So it has two things. It reminds the physician and the patient. It also has the power of giving precision treatment to patients. So CDSS is the need in the health system. Now you can color this, say that this is one swallow does not make a summer. You need multiple levels of care. In fact, we did the SIM card trial with China. It was a trial conducted in Tibet and in Haryana, in a state in India, and we showed that at a community level also it works. So we evaluated this at tertiary care, community level, statewide, and at the level of primary care. Now it is part of the national program where there is an effort to digitize health data and provide electronic decision support to patient care. Moving on, during the COVID pandemic, we realized that telemedicine could be the future. So we created an interoperable platform. What is an interoperability? If you look at your iPhones or Android phones, they don't talk to each other. It's very difficult to make them talk to each other. So we created a platform in which each device can talk to one another, and we developed this device with a point of care device which could give you blood tests, a portable echo, the Lumify device from Philips, digital ophthalmoscope, AI enabled ECG, and a smart stethoscope, and evaluated it in multiple locations in India, and so it's been published, shows that we can have a better blood pressure and better diabetes control. Now, coming back to where we can use AI for remote care, we are looking at a multimodal approach in terms of home-based care for heart failure. It's a structured multi-component program for assisted home-based post-discharge care using digital health technologies and guideline-treated medical therapy. This is a trial which is to begin. It's an individual randomized trial of 2,500 patients. It's based on strong heart failure trial recommended guideline-directed medical treatment, and there is a wearable device which has an algorithm. It takes into account demographics, cardiac parameters, activity, pulmonary congestion, symptoms, and so on, and predicts the when which patient can have a complication. Finally, what does the future entail? I think we are at the foothills of looking at large language based health management issues. Chat GPT, for example, now provides accurate answer almost to 90%. If we use our knowledge and actually utilize it, it can be a good proposition in terms of managing patients. Second is we need to integrate care of technology for CVD. I showed one example in the telemedicine, but there are various examples, including smart clothing and several others. However, we should be cognizant of the challenges in implementing AI models in public health. One is data quality. We should ensure that the data is accurate and representative. Digital literacy is very poor amongst the community, so we need sufficient digital skill for effective use. We need the clinician trust, building trust through transparency, reliability, and actually validating whatever you do, and real world effectiveness. This is where we are lacking, and we need to show real world effectiveness. So cardiovascular practice is inherently multimodal. The future of AI model in cardiovascular disease lies in multimodality and personalized care. So for this, we need system-wide approaches where we have embarked upon educating the community in terms of digital health in 6 villages across India, where we are paired with medical colleges and we're using medical students to train them in digital health. So we really need to create a movement. So this is my final slide. We in science go to molecular level, atomic level, we go to the minutest level, but when we have to provide solutions to patients, it has to be holistic. Thank you very much.